Hi.
Hello, welcome to MHTV. Tonight, just before we get started, I just want to give you a heads up that we're going to be talking about suicide, self-injury, and if that's not for you, it's really not a problem. We'll see you next week where we're talking about CAMS services. But if you do want to stay with us, don't feel obligated to stick it out if it's too hard for you or you want a break. We'll also be posting up some things that be helpful resources afterwards. But the aim of this discussion is to really understand the nature of the issue and think about some of the things that we can do to help our community. So that's what we'll be talking about tonight. Before we get started, let's go to Dave, because obviously we want to hear from you. We want to hear what you have to say if you have any questions. And Dave will tell you how you can join in.
Well, thanks, Nicky. Hi, everyone. Yeah, just same as always. If you want to get involved in the conversation tonight, there's a couple of ways to do it. The first is on our Facebook live feed. All you need to do is pop over to the right side of the screen and type in any questions or comments or thoughts that you've got about the topic we're discussing tonight. The other option is that you can head over to X and you can post some X's using the hashtag MHTV. And obviously, we'd be really glad to see those as well. But as Nicky said, I'll be doing my best to keep on top of the conversation on social media and sharing some of the resources that our guests are wanting to get out there tonight. Without further ado, straight back to you, Nicky.
And you can call X Twitter if you want. We're not bothered. It's fine. It's fine. So let's come to our fantastic guests. So we've got Karen and Samantha who've written this piece of research up, which we're going to be talking. But I think it's always best for people to introduce themselves. So Karen, can you tell us a little bit about yourself?
Yes, hi, thank you. And thanks for having me. It's great to be here. So my name's Karen Lascelles. I work as a mental health nurse consultant in Oxford. I've been nursing for a long time, and I've worked in the field of suicide and self-harm for the last sort of 15 years or so. And, you know, as a nurse consultant, that involves sort of research, practice, strategy, teaching, and all of that kind of stuff. And I'm very fortunate to have good links with Professor Keith Horton at the Oxford Centre for Suicide Research. He, myself, and Sam formed the research team that undertook this work that Sam did, as a researcher, did all the work on, really.
So Sam, tell us a little bit about yourself.
Hi, thanks, Nicky, for having us again. So hi, my name's Sam Groves. I'm a research assistant at Oxford Health, and similar to Karen, so I work with Keith at the Centre for Suicide Research at the University of Oxford as well. So I joined Oxford Health around 2 years ago, and I've been working on this project related to suicide among nurses since that.
Yeah, so perhaps that's the best place to start for us to understand a little bit about what was the study about, what led you to undertake it?
So recent statistics from the Office of National Statistics have shown that female nurses are at increased risk of suicide compared to females in the general population, and this has been a trend across many years. So despite kind of increasing interest and kind of concern on this topic, including during COVID, where there was lots of news coverage about suicide among nurses, was kind of increasing concerns. But there hasn't been a real kind of summarization of the literature since 1999, which was by Keith Horton, who conducted a systematic review, again kind of highlighting lots of gaps in the research surrounding suicide in nurses. So there was a real need to update the literature and see what was out there. So we were commissioned by NHS England to conduct a series of projects related to suicide among nurses. So this included the systematic review and also studies looking at media reporting of suicide related to nurses, and also the characteristics of self-harm among nurses as well.
So what did you find that was different? What's the sort of nature of this issue?
So we found kind of similar, again, to Keith's research, that there's long-standing evidence that nurses are at increased risk of suicide, and specifically strong evidence for female nurses. So this includes evidence from the UK, from the US, I think Denmark, Australia, New Zealand, they're all kind of showing this trend. And this trend, again, has been for many, many years. And it's continuing to be, so nurses at increased risk. And we found many factors that may contribute to suicide among nurses. So this might include psychiatric issues and mental health conditions, physical health conditions, occupational issues, relationship issues, and all of these factors are likely to interact with each other to contribute to this kind of increased risk.
It's interesting what you're saying, because obviously when people think about suicide, they see it frequently as a male issue. And so I can understand how this might be a population that's quite distinct that we're perhaps overlooking. And I guess as well, I mean, correct me if I'm wrong, there can sometimes be a bit of them and us thinking with staff, in that you always assume the problems are on the other side of the glass, and you don't necessarily think that actually it's something that happens to nurses. Karen, is there anything you wanted to say?
Yeah, I think you're right, and I think in certain areas of healthcare, there's sort of a bit of a stigma by association that, you know, we know that there's a big stigma out there linked to mental health problems and to suicide, whether or not suicidality is in the context of mental health or otherwise. So I think often, you know, people may not realise, but there is that stigma by association going on, that people worry about what they're experiencing and thinking and feeling, you know, and perhaps don't help seek for that. Although interestingly, one of the things that we did notice in this research was that nurses were seeking help, and you know, were seeking help from primary care and psychological support. And I suppose that was something that led us to think, you know, that's an avenue for consideration with regard to interventions in terms of monitoring and asking the right questions and inviting nurses to share how they're feeling, and just being curious, and perhaps diving beneath the initial reason for presentation.
Yeah, I mean, if we don't have these conversations, I can't imagine where we're going to end up. So tell us a little bit about how you found the information. What was the methodology?
So I'll take that one. So we conducted a systematic review. So it's basically a method, set method of summarising the research evidence on a given topic. So for us, it was summarising global evidence on suicide and also non-fatal suicidal behaviours and thoughts among nurses and midwives. So there's usually quite a typical stages to a systematic review. So you conduct quite a detailed search of academic databases and sometimes grey literature, so studies which might not be published in journals but elsewhere. You then screen your studies against your eligibility criteria. So for us, if it focused, because wanted to be quite broad, if it focused on suicide among nurses and midwives, and it was published, it was largely eligible for inclusion. And then we also extracted then the data from studies which was related to our research questions, and then assess the quality of these studies as well, using an adaptive tool which was previously used by Keith Horton and colleagues, which looked at suicide among anaesthetists. So we adapted that tool to help with our review, and then you use kind of all the data you've extracted to then synthesize together for the paper to answer your research questions.
I see. So it's kind of a structured way of bringing together lots of different information that maybe has been asked in different times and in places in slightly different ways, and bringing it together to answer the question that's pertinent now, which is linking about suicide and suicidal behaviour amongst nurses. So did you find any difference between different countries?
So we found it's quite interesting. So there's quite a lot of difficulties kind of comparing across countries, because there's also different definitions of what a nurse is in different countries, and also in some studies nurses were grouped with midwives or nurses were grouped with healthcare assistants. So it's really difficult to kind of compare across countries. But I think we mentioned our discussion, it kind of leaves an interesting question of the definition of a nurse and whether that would be helpful for future research to allow comparison across countries, but also across roles as well. For example, we don't know at the moment if the specific specialities of nurses that are at increased risk particularly. So, for example, mental health nurses or general nurses. So that's a really big avenue for future research.
That's an interesting one, isn't it? Because we don't necessarily have the classification of mental health nurse in other countries, so you couldn't really compare it. Yeah, I see what you mean. Complicated stuff. Well,
I was just going to add, I suppose most of the countries, if I'm right, Sam, were sort of westernized countries as well, weren't they? There were a couple of studies from Asia, but I think, you know, mainly they're from Australia and America, UK, and sort of Denmark, Norway. So I think that there's a real need to think about nursing and nurses in countries further afield. But of course, then you've got not only language and interpretations of nursing, but language and interpretations of suicide, because different countries will have different ways of articulating that. Some countries don't have suicide in their language, in their lingo, you know, and so rates and numbers will be even more difficult to ascertain. But there is a need there, I think.
Do you think stigma might make a difference to whether people report or classify something as a suicide?
Yeah, I think stigma is a big thing, and I think that's why in certain countries perhaps they haven't developed a language around it, because it's, you know, culturally they have different ways of making sense of mental illness and suicide, and it's very different to a sort of a Western understanding. So we need to develop ways of researching in culturally sensitive ways to really understand you know, what the risks are and how to support people
what do you
within
think
and outside nursing.
Absolutely. What do you think the most important findings from your study were? You don't have to agree.
Do you want to go first, Sam?
Sure. I think one thing we found from the review is that at the moment there's a real lack of interventions that are tailored to prevent suicide in nurses. So we found we found 3 studies, but it's based on one intervention in the US. That's it's called the HEAR program. So it's called the Healer Education, Assessment and Referral Program. So within the workplace, there's education to nurses around suicide, around their mental health, kind of trying to break the stigma, but also then anonymous risk screening as well. So the workplace sends out a risk screening questionnaire for suicide, and those individuals that are above a certain threshold are then referred on for further care. And they found that although there were individuals going through this system, and it was anonymous, there was still quite low response rates, low amount of nurses completing this. So there still could be something around nurses fearing, highlighting that they're struggling to their workplace, even though it is anonymous, and there still might be quite a lot of fear around it. So I think there's a real kind of potential highlighted by the review for thinking of other ways to support nurses who might be at risk.
That's a really good point. I think the idea, of the sort of self-conceptualization of being a nurse. I mean, I think about how much of my sort of self-esteem as a nurse and as a person is probably based in being able to cope, being able to manage, being the person who doesn't panic, and it's not real, you know, because it's a role, isn't it? And we all panic sometimes. We're all overwhelmed at sometimes. We all get really sad sometimes. And if you don't, then you're kind of not living your full life, I think. But sometimes when you have that identity so firmly in your head, which doesn't allow you to admit that maybe you're struggling. So it's not just that there's nowhere to tell people, but there's actually no way to think it first, if you know what I mean. How clear I'm being now. What do you think?
Perhaps that's perpetuated a little bit by the sort of angel metaphor. You know, that if we're these angels, and you know, then maybe that adds to this sort of inability to be able to accept that we've got foibles like the rest of the world. So
and complicated lives.
And I think on that point, actually, I suppose the main thing for me of the study was that the risk factors, if you like, associated with nurse suicide are not necessarily particularly different from the risk factors for anybody. And I think it's really important that we highlight that, because one of the things that we still don't know is why is it then that nurses are ending their lives by suicide? Is it that nurses, even prior to joining the profession, have predisposing factors that sort of make them vulnerable to developing suicidal thoughts and behaviours if some kind of adversity occurs. So was it pre-existing, or was it actually the profession? And even if it was a pre-existing vulnerability, perhaps there are aspects of the profession that brought that to the fore, or maybe it isn't. Maybe it's still in somebody's social context, actually. And that's really difficult. And this is why qualitative studies are so important. And that's the next step. And Sam's going on to do a DPhil, really specialising in this area that she can talk about in a bit, that will add to this. But I do think, for me, then, that's kind of one of the main things. And when we think about interventions, we need to make sure that we're not singling nurses out as being something wrong with them. It's a fine balance, isn't it? It's like nurses need to be allowed to be open about the fact that just like anybody else, they're vulnerable. And, you know, the occupational aspects of nursing, like long hours, overworked, that all of that goodwill work that we all do at the end of the shift, so we get back even later, and then we're with our family and we're tired, and then by the time we sorted the family out, you're just exhausted. So your sleep might be impaired because you're worrying about what's gone on at work, and the emotional responses come out then. And you know, if that continues, then that's going to make you vulnerable. And we need to sort of recognise those patterns, and they will occur in nursing. And how can we support nurses to seek support and get the right support that's tailored to their individual needs?
I think you make a really interesting point there, aren't there? There is something about sort of nursing being seen as special and different. And I think, you know, the angel stuff. And then also you had a lot of kind of like martial kind of ways of describing nurses in COVID times. Like they were superhuman, like they would go on to do more and above and beyond. And it's just not possible. And then now you're getting these kind of narratives like even nurses use food banks. It's like, well, people use food banks and nurses are people. So they're not exempt from real life and real life stresses and strains and sadnesses. And to act like they're different to that, or it's particularly unusual when real life happens to them, is really, you know, they're not unicorns, they're people. It's a really weird way of thinking about things. But I can also see what you're saying as well about it, about maybe there needing to be some kind of thought to the way that message is given, so that nurses can actually feel that it's for them and to take that on board. Yeah, you've made some really interesting points. So, you know, can we talk just a little bit more about the risk factors and what we can do to help, what we need to be aware of?
Sure. I'll pass to you, Sam.
Oh, sorry, I was on mute. So from the risk factors, so firstly, with thinking about mental health conditions, so one of the findings, again, was that nurses who died by suicide had higher rates of mental health conditions from the evidence in the US than individuals who died by suicide.
Do we know what kinds? Are we talking about just depression and anxiety? Are we talking
so they're all grouped together, so we don't know, but that would be really interesting. And again, about having high amounts of service use as well. So I think it's a real think about what we can do next, that those interventions where nurses do go and seek help. It seems like at the moment the support might not be working for nurses, so we need to think about then how can that be improved, and that's a real opportunity that nurses are already seeking that help. So what can we do then to help those nurses as well? There was a really interesting study, so a mixed method study from the same team who created the HERE programme, that looked at risk factors for among nurses who died by suicide, and they found that job loss was a real so it was nurses who died by suicide where an occupational issue was cited kind of in the medical notes or law enforcement notes after their suicide. But among that sample, I think it was 92% had either lost their job or potentially going to be losing their job. And that potential job loss could have been due to a range of things. So it could have been medical retirement if they had kind of a physical or mental health condition, but it also could be that they were possibly under investigation, for example, if they were using substances, or there was an issue at work. So it seems to be there's a real key time and vulnerability among some nurses, and if they are in a position of potential or they have lost their jobs. And there was some really interesting work done with doctors, I think a few years ago, looking at fitness to practice procedures and how they could be improved. And I think that could be really key and really quite important to look at for nurses as well, as what are nurses' experiences of going through that in the UK, and what can we do to support nurses more as well.
It's such an isolating experience, isn't it, being under investigation, because you're told you can't talk to people. And at the time when you're feeling desperate, it's huge amounts of change, potentially job loss, which is identity and financial. It's really high. It's weird, isn't it? When people put this stuff out, everyone's like, oh yeah, but if the research isn't done to make it really clear, it just drives us by and people don't realize it. Thank you for that. Is there anything, Karen, that you wanted to add to that?
I absolutely echo about the investigations, and I think that probably is it filters down to what are not fitness to practice investigations, but investigations within organisations after serious incidents. That if they're not done in a sensitive way, then people can feel that they're being really scrutinised in a way that they're going to be held to account and blamed. And if it's a situation where it often is in these, if there's a investigation where it might be a death by suicide or it might be an unexpected death, then invariably that individual is experiencing an awful lot of emotional responses anyway, and then that's perpetuated. So I think as trusts as well as the regulatory bodies have some thinking to do about how well they support, and there's lots of work going on it, in the just and restorative culture, and often I feel quite confident, say in a number of organisations that I'm linked with, that there's no intention to convey a sense of blame, but that doesn't mean that staff don't feel it. And there's often a dissonance, isn't there, between what we think we're doing and how it's actually experienced by staff. So I really think we need to think about that. And then the other thing that came up a lot was alcohol, was substances. And I suppose there's a lot of stigma there as well, in that people won't necessarily reach out for support with substance use because they would worry maybe about disciplinary action or maybe about being frowned upon. So we need to think about how we can reach out to people there at that early stage, right in training, to think about ways to maintain your well-being, to look after yourself. The ease with which sometimes alcohol seems to be a prop, and it's easy and it's accessible, and when you've not got much time, it's quite easy to knock a drink back, but actually the consequence of that can be really damaging for people. So we need to really be talking to people, students, about that, and equipping people early on in their career with strategies to try and deal with life stress and professional stress.
You're mentioning some really contradictory things as well, aren't you? Because exactly as you were saying about investigations, by their nature, they're complex. They take ages. And so when it's your job to do it, a month or 2 months feels like you're really gunning it. You're doing a really swift, thorough job. But for somebody who's waking up every night having not slept properly and then trying to go into work and feeling uncomfortable, or that people are looking at them differently, that feels like an eternity. And when people aren't sleeping properly, they stop seeing things so clearly, it gets really complicated. And the other thing, exactly as you were saying about alcohol, is sometimes, I don't want to get myself in too much trouble here, but I think about my student days, and I think about my early days in the NHS before I sort of found my feet. Everything was pub-based. Everything. All the kind of debriefs, after a coroner's court, after a particularly difficult shift, pub. And then all the leaving dues, and then we wonder why people have that experience of using alcohol to manage. And it's so obvious why this happens. But I think having sort of more mixed teams has led to, particularly from my experience, us making different plans. But it's always quite complicated, isn't it? Because it's like, what can we do that's not the pub? It always feels like it's like a big effort not to do that. So it is something that's really embedded and almost invisible because it's so prevalent in cultures. But I think you're right about this idea about working in ways that are more nurturing, self-nurturing.
But interesting is you're saying, we all used to go to the pub or the social club or wherever, and it was alcohol based, but beneath that bit was the peer support. And it was about being with your colleagues and talking to each other, because that's who really gets it, is your peers. So I think we really need to optimize opportunities for healthy and nurturing peer support that's accessible. And, you know, perhaps that's more than reflective practice at work. It's more than that. It's being able to sort of have some kind of network or place where you can go to and say, you know, this is how I'm feeling. And maybe it's anonymous peer support, but it's with another nurse who is able to say, me too, I've been there and this is what I tried. In the same way that we use peer support workers in mental health care. I think there's lots we can do there.
I'm getting some questions through. Dave, should we come to you?
Yeah, just on the kind of conversation so far, there's just three things that I've felt it might be helpful to reflect on. One of them is that the support that's available after you know, someone's died by suicide in an NHS organisation. That I know kind of a couple of years ago it was recognised to be exceptionally poor in terms of, you know, staff not knowing how to support each other in what, you know, would be an exceptionally distressing situation and an environment. And it's great that the Samaritans and NHS Confederation has done a joint piece of work that they call postvention, you know, after someone's died by suicide in a workplace setting. The other thing that I wanted to mention was that kind of local support that can be made available. That there's been some great work that Emma Wadey's been leading on professional nurse advocates. I went to a conference a couple of weeks ago where some of these issues were discussed there, and I'd recommend if anyone wants to get any more info, either follow Emma or have a look at the Twitter thread that I did at the time, and I'll try and find it and I'll put it on the thread for tonight's conversation. And then the third thing that I wanted to say, I can't actually remember what it was, but it will come up in my head, I'm sure, in the next few minutes, and I'll WhatsApp it you, Nicky, and you can pull me back in at that point.
I guess I'm confused by.
No, I've not got any questions in yet. They were the kind of comments.
All right. So did you want to say anything about those comments, Karen or Sam?
Yeah, certainly the work that Ruth Riley led on in relation to postvention that was very much supported by Emma Wadey has recently been published, you know, into a guidance for organisations that really is excellent. And that's for when a staff member ends their life by suicide. So what I'm hoping happens now is that, you know, chief nurses and you know, exec teams pull together teams of people to really think about implementation of that. Now, the other thing to think about is when patients end their lives by suicide. And we've developed through different research a few resources around that, which I can share with you, and that might be helpful. And I think that's important because dealing with, you know, these painful events, being exposed to these painful events can, you know, if someone's already vulnerable, it can increase that vulnerability. So support when a patient dies by suicide is just as important as support when a colleague dies by suicide. But sometimes the mechanisms of that support might be slightly different. So I'll share those resources. And yeah, I couldn't agree more about with professional nurse advocates and professional nurse educators. I think those are going to be really, really important roles. And I still think that alongside that, some kind of other peer support network will be helpful. And I think if we cover the whole spectrum and people have got lots of different ways to access support, that's what we need to do, because whatever research you do, you cannot have one size fits all. We need to have individualized, tailored support, and that means to have a menu.
Got some questions come through. They look like student questions. Don't want to be critical. So the first one is from a student who's been told off for saying for not doesn't know how to describe the incident that they said someone had committed suicide and they got told off they hadn't said the right thing, but they don't know what they should have said. Could you help with that?
Yeah, and yeah, thank you for raising that, because that's a really important point. I think a lot of us are socialized into using the word committed, and the reason that perhaps you might have been told off, I hate the word told off, and I'm sorry that
that's what they say.
Yeah, that's
I bet it felt that way too.
Yeah. The reason for it, just so that you understand the context, is that, you know, historically suicide was a crime. It still is in some countries, but in the UK in 1961 that changed, and it was no longer no longer considered to be a crime. However, the word committed still has the criminal connotations, and this is why over a number of years there's been lots of campaigns to not use the word. And the preferred word really is, you know, someone died by suicide or someone ended their life, and that's okay to use in whatever context it is. If you're talking to a family member, or someone who's bereaved by suicide or whatever, then ended their life by suicide is probably the preferred way of saying it, if you know that it's a suicide. If you're working with families where they may not have that verdict yet from the inquest, then they may not want to use that term, and so ending their life is enough, because ultimately that's what's happened.
Yeah. And I think we can sometimes forget how it feels for families, because there is the stigma around that anyway. Plus you've got the grief and despair, and sometimes suicide can be quite a complicated type of death to process, because you might have anger, confusion on top of grief and loss, and all gets muddled up together, so it can be really quite a confusing experience. And when you're speaking to somebody who's lost someone by suicide, it's something that sticks in their mind forever. So it is important that you are as compassionate as you possibly can be.
Absolutely.
I'm sure you are. Yeah. Someone else said, what would I even say to a colleague? How would I ask if they were okay?
Yeah, and you know, that's again a really good question, because we've done some work locally, and and this was when a staff member had ended their lives by suicide, and their colleagues felt so guilty, and they said, gosh, you know, I'm really good at speaking to my patients and asking these questions, but I didn't even do it. And actually maybe I did think there was something going on, but I didn't know what to say. I didn't want to, you know, be nosy and stuff like that. So the message consistently is if you're worried about somebody, just ask, because they can tell you that, you know, to go away. But they, you know,
that was a self-edit of heroic proportions. Thank you for that. Yeah, they may decline to answer, for sure.
They may decline to answer. Yes, but equally, you know, they might say, "Oh, you've noticed? Yeah, I'm feeling terrible." So I would say your anxiety and your fear about what to say to your colleague is your anxiety and your fear, and not theirs. So just try and transcend it, jump over it, and just say, "Are you all right? I feel a bit worried about you," because that shows that you care, and that's the most important thing.
Yeah. And if they are fine, so what?
Yeah.
Does it?
Yeah, they still know you care.
It's really important that you said something. I guess we're coming sort of towards the end. We've already done sort of half an hour or so. So I guess just to recap, we've talked a little bit about the risk factors, and we've talked a little bit about some of the things we can do to help. But is there anything else that we could be aware of that would be useful?
Do you want to go first, then?
Sure. So we could just quickly go through the other studies that we've conducted related to it. So, so one of the studies looked at the way that the media over, I think it was between 2018 and 2021, reported on the suicide of nurses, and obviously that was also during the COVID-19 pandemic. And we conducted this piece of work with Samaritans, and it was conducted because we know that irresponsible reporting of suicide, so for example, very detailed descriptions or very kind of sensational language, can have the ability to impact individuals who are already vulnerable to suicide. And we know now from recent research that nurses are at a group at heightened risk. So it's really important to see.
Interesting. I didn't know that.
Kind of how it's been done. And so we work with Samaritans, and they have a guideline on how the media should report on suicide, and we found that overall most articles were seen as acceptable, but there was still some very kind of common issues. So there was still lots of articles that mentioned the method of suicide, including the method in the heading. Some, I guess, linking to the identity again, some use very sensational language, and this was particularly, I think, apparent during COVID. So there was lots of kind of selfless or heroic nurse dies by suicide, and then there was still some stigmatizing language as well. But also kind of what we found, again linked to this nursing identity, is that the majority of the articles were really focused on that individual as a nurse. So the vast majority of papers said in the headline that the individual's a nurse. Lots of papers said the exact workplace of the nurse, showed pictures of the workplace, sometimes even naming colleagues. So it was very kind of really
very intrusive, isn't it?
Yes. And
the person has done nothing wrong. It's not like they're investigating a crime or anything like that. It's a really strange thing to do. When you think about the fact that you're looking at someone's most intensely private and sad moment, to sort of turn it into entertainment like that is disturbing, even before you get to the fact that you might actually be impacting other people's well-being. It's weird. I never really thought about it that way, but you're right.
Yeah, and I think one of the key kind of implications from that work is to think about, thinking about postvention as well, that if there is the suicide of a colleague in nursing, the way that those individuals are supported if there is media attention. So, for example, if there's a contact at the trust that kind of handles if the media gets in touch, or there's someone to talk to if someone's upset by what they've read. Yeah, so that was the first piece of work. I don't know if you've got any other comments about that, Karen.
I think you're well. So before Karen said, I think you're absolutely right about giving people that warning about media, because I can remember having colleagues die by suicide and the ward being rung up by local newspapers taking a chance. So don't say anything. Forward them on.
Yeah, it's a good message if there are students, isn't it, on the call. If that ever happens to you, you just direct them to your communications department, and they should know that anyway.
They do know. That's the thing. That's what's so annoying about them. Yeah. Sorry, Karen, I interrupted you. I didn't mean to.
No, I didn't have anything to add to Sam, so she can move on to the.
And then the other piece of work. So in our review, we found there's lots of studies looking at suicide rates, and then also lots looking at suicide ideation, but much less research looking at self-harm. And we know that obviously not all self-harm has suicidal intent, but it's a really important risk factor for future suicide attempts and suicide. So we looked at data over an 11-year period using the Oxford monitoring system for self-harm. So this is if an individual presents to a hospital in Oxford after a self-harm episode. The individual and the clinician go through a psychosocial assessment, and that data is gathered then into this monitoring system. So we extracted all the data where the individual's occupation was listed as a current or former nurse or midwife. And we, over the 11 years, I think there was 107 episodes of self-harm by 81 nurses and midwives. And really there was lots of findings that echoed the reviews. So many nurses had used alcohol as part of the Self-Harm Act, or high levels preceding the Self-Harm Act, or in daily life. And the issues, so there's a list of problems that the clinician and patient will rate of factors which may be contributory to the self-harm episode. And again, common issues were issues with partner or relationship, occupational issues, mental health issues, and alcohol issues as well. So these factors are kind of just as important thinking about self-harm in nurses as suicide as well.
Karen?
Yeah, I suppose my addition to that is really from a personal sense, because I used to work in the liaison team, that this research was done for a number of years, and I've met a number of nurses who've come in following self-harm, and I suppose, it's all anecdotal, my feedback, but, people often, they wait so long until, they're in such desperate situations when they come in. And I remember feeling so relieved that they did come in and so willing to engage and talk. And there's so much that we can do for people. And some of it's about validation, and some of it's about letting people know that there is support and making sure that they get it. So I suppose the message in there, for me, is for anyone listening, and also to share with colleagues, is that do seek help and do seek support. Definitely. And there are people there, and I know that health services are stretched and stuff like that, but sometimes just being able to talk to somebody about how you're feeling and have them listen, like on the Nurse Lifeline or Samaritans, or at work or at your GP, it is worth doing. You're not alone. You're absolutely not alone. And I just want to make sure that there's some positive messages there, that, you know, there is help and there is support. And do you know what, as well, there's an awful lot of time and energy going into thinking how to better support nurses. You know, and Emma Wadey is very much involved in that, and a lot of organisations are. So I think things are going to get better in terms of support for nurses.
Yeah, and I think as well, you're right. It is an uncomfortable and a sad and a difficult subject to talk about, but dangerous if we don't. Really dangerous not to, and not to think about what we can do to help and support each other, and how. And you were saying as well, Karen, about the importance of community and being around and asking each other, and sometimes a moment's discomfort is what all's needed. And as well for you, Samantha, thank you for gathering all that data together so we've got something to understand. I guess we'll just whip round, see if anybody wants to leave anything as we finish up. And don't forget, we are tweeting out information around Hopeline UK, Papyrus, Samaritans, and Nurse Lifeline as well, if this is something that you found a difficult subject and you want to talk to somebody. But also, if you're thinking about somebody, should I mention something to them? Should I check in on them? Check in on them. Just check in on them. So Dave, is there anything you wanted to add?
I think one of the things that I've been reflecting on as the conversations happen tonight is, in one way, how positive it is that this conversation is happening, and the amazing work that you've both been doing on this subject and topic area. And I kind of think back to 2020, I think it was, when the National Confidential Inquiry into Suicide and Safety and Mental Health came out with its report about suicide by female nurses, and kind of hoping that that would be a really strong trigger for work to be done and for better support made available for what should be a group of staff that we desperately care about. I think the other thing that kind of reflecting on tonight is the way that work can actually make you seriously unwell. And employers have got a really important role in making sure that they can do everything possible to make sure that work is rewarding and not an environment where people are made more unwell. And I kind of think back to the letters that Dido Harding sent in May 2019 and Parina Issar sent in December 2020, following a situation that happened in a trust, in one of the London NHS trusts, where, you know, they found that the work, the kind of the things that the trust had done actually contributed to a staff member's death by suicide. And I think the other thing to kind of, you know, think about in all of this, and the work that I do day in, day out supporting our members, is the stuff, you know, that the NMC have also done in recognising the role that you know, fitness to practice can play in putting extra pressure on nurses and midwives and nursing associates. And I think, you know, fair play to the NMC, they have recognised the role that they have to play in that as well. So kind of all those sort of bubbling through my head tonight as we've heard some, you know, great kind of conversation with Sam and Karen.
And Sam, was there anything you wanted to add? It's not the law, you don't have to if you don't want to.
No, just to echo again that if there is anyone thinking about accessing help, then definitely access it, or anyone thinking about asking someone else, definitely ask.
Right. Karen, anything from you?
No, just thank you. And don't forget, nursing can still be a really good career.
It's a brilliant career because we tackle the difficult subjects.
Yeah.
So thank you very much, everybody, for your time today. And I hope this has been something which has been interesting and thought-provoking. We'll be back next week talking about CAM services, so children and adolescent services, and have a lovely evening and do something lovely for yourself tonight. So thank you very much all. Good night. Bye-bye.